Interceptive Orthodontics Part 6, Expansion of the Maxilla in the Absence of a Crossbite. My name is Dr. Jean-Marc. I'm from IFDE. So the expansion of the maxilla without a crossbite has the following indications. A narrow and triangular maxilla, as you can see right here, very tapered. Lack of transverse development. Molars are rotated mesially and you get these very triangular shape. You get moderate crowding. You can see V-shaped incisors. Lack of space for lateral incisor. And the teeth are a normal width or slightly wider than they should be. Patient presents with some crowding in the mixed dentition. What can you do? The first answer that you can give is, I don't know much about tooth eruption and dental alveolar development. Not much I can do, let's wait and see. Second solution is to extract the deciduous canines in order to align the incisor. This will result in alignment of the incisors, but it will be to the detriment of the permanent canine space, which may result in a route for permanent teeth extraction in the future. A third solution is the expansion of the maxilla that will result in a wider arch and promote some dental alveolar expansion of the lower arch in certain conditions. This slide, we saw that Dr. Adkins in 1990 reported that the arch perimeter increase is about 70% the increase in arch width, meaning when you expand the maxilla by about a millimeter, you will get 0.7 millimeters of arch perimeter to align the dentition. That's an important finding, as it will help definitely into tooth alignment. The case we just showed you a few slides ago had some moderate crowding, overlapping lateral incisors, and was treated with a maxillary rapid parallel expander. And 18 months later, the patient came back, and you can now see that no primary canines was extracted, and the anterior dentition is now fairly well aligned. So this patient is now placed into a recall list where we are going to wait until all permanent dentition is present before we start any type of orthodontic treatment. This patient presents a chief complaint of blocked out maxillary lateral incisors, a tapered arch, and prominent central incisor. She's just turned 8 years old, and you can notice that the upper arch is tapered. There is some lack of space for lateral incisors, so we prescribed a rapid parallel expander that was used to expand the maxilla by about 6 millimeters, which opened up a central diastema, which eventually disappeared. And you can see after 6 months of treatment, at the time when the maxillary expander was removed, that the anterior dentition is now well aligned. There was space created for lateral incisors, and the upper arch is now ovoid instead of tapered. The conclusion of this procedure, which consists of using a maxillary rapid palatal expansion in the mixed dentition in the absence of a crossbite, are divided in two folds. First, the indications. The rapid palatal expansion should be considered in the mixed dentition if the teeth are of normal size, the palate is narrow or tapered, and less than 4 to 5 millimeters of space is required. In this situation, it is advisable to slightly overcorrect the expansion and let the occlusion settle at a future date once the expander is removed. The contraindications are if the patient presents with severe crowding, teeth larger than normal, and if the upper and lower arches are normally developed, you should not proceed to this type of maxillary expansion. There is a second problem too. If there is lack of overbite, you should consider the fact that maxillary expansion tends to open the bite, and it may not be the best procedure if the patient has already an open bite tendency. And the final conclusion is an indiscriminate expansion to avoid premolar extractions when you have severe crowding often leads to undesirable results. So this is not a procedure that should be performed on any patients who are exhibiting some crowding between the age of 6 to 10 years old. You have to perform a complete orthodontic examination before you decide to pursue in this route.